right side, he's not relaxing. I could feel that because his hamstring tends to, he's not going to want me to dislocate his knee anteriorly. And the way I've been treating him, he should be afraid of that because I'm pretty rough with him. So when I talk sometimes I don't think about my handling. Like, see? Okay. But that's pretty lax, and that's laxer than the other side. Now, I said the other one's a half a centimeter. This is a centimeter or more. Okay? So that's the anterior drawer. I mean, I'm not going to keep going. Okay. Posterior drawer, same position, and I just push the tibia posterior, and that's firm. There's not much happening there. So PCL, if you look at my thumbs on the tibia relative to the patellar tendon above, there's not much movement there, 1/4 of a centimeter or less. But when I go here this way, and it keeps it coming. Okay? All right, now, the other way, say the person had a little bit of a sag, so the tibia is backwards, so there's some lost integrity of the PCL, the tibia is free to move back. I push it and it goes back, or he's relaxed and the tibia is more posterior, PCL is torn. They can do an active anterior drawer, and we'll see that tibia move like that, and it'll move to, now he's doing it, and again, it's just like an anterior drawer. When I say, go ahead and try to extend your leg, I'm blocking it from happening here. And you'll see the tibia move. That's a sign of an instability. Okay? The tibia is pulled forward without an ACL, and it keeps coming. Now, normally it would just stop at the patella. Okay? So, if it was more posterior to begin with, that's indicative of the instability, just the PCL's torn. But if the tibia goes past the angle of the patella, then it's an anterior instability as well. Does that make sense? So you're just looking at the excursion. But you can see the force of the quadriceps on the tibia with that glide, and understand that in an open chain situation, after an ACL reconstruction, how detrimental that could be. That's pure tibial translation. And we're trying to protect the ACL from pure tibial translation. Last thing you want to do is have them do active knee extension, full arc, right out of surgery because of all that translation that's happening. A long time ago, probably before most of you were born, there was a downhill skier, a woman skier named Peekaboo Street. You guys heard of her? Peekaboo, solid downhill skier. She had thighs bigger than my trunk. She was just, and she, Olympic gold medal, I think she finished silver, I don't know, whenever, 12 years ago, wherever it was, in Utah or whatever. But anyway, while she was training, she tore her ACL, and there was no direct injury. She didn't fall. Her quadriceps were so strong, she dislocated the knee anteriorly. The muscle of the quadriceps contracted so forcefully that it pulled the tibia forward and tore ACL. So there is such thing of having too strong a muscle. But at any rate, or that was the hypothesis. Maybe it was just legend, so that she got more attention about it. So that's anterior drawer, posterior drawer, and that last one you did, go ahead and do that again, was the active drawer test. Okay. All right, so let's play with those, and then we'll